Okay. Hello.
Hi.
Well, it's 7:01. So what I'll do is start very gently. Welcome everybody. People are rolling into the meeting all the time. So I'm going to speak, but say nothing of any importance, which comes naturally to me. A lifetime of practice. We have Gemma ready, and she's the main event. But in the meantime, just for a few moments, I am just going to show you the slide. Now, we did have an idea, an agreement for 5 lectures. And our 4th lecture, we've had difficulty scheduling it. So rather than lose the sort of continuity of the Tuesday nights in this winter slot, we're going to move Vijay Pandarandaran from La Jolla, who's an honorary chair with us here in Liverpool. We're going to move him to next winter, which he's agreed to do. So in fact, next week we've got a gap. And then the week after that, we've got Meroad Evans from Valendra in Cardiff, who's got an honorary chair with us here in the Head and Neck Centre. And indeed, Terry Jones, some of you might have heard of. And they're going to be talking about the interaction of radiotherapy and surgery in HPV positive oropharynx with reference to the Pathos trial. So that should be great. But just as a reminder, that is in fact in 2 weeks' time. So we haven't got a lecture next Tuesday. And that will be the last lecture for this series. We have learnt over the years to avoid the summer slot because people have other activities in the evening in the summer, which means the attendance wasn't as good. So I am going to stop sharing that. That should have worked. And it's my huge pleasure to introduce Gemma Cherry. Gemma's a clinical academic, but a psychologist. And she works as a clinical psycho-oncologist at the Royal. And she has a senior lecture post at the University of Liverpool. And Gemma works with us on a number of projects in and around head and neck cancer, but does actually work in other areas of research as well. And she's particularly interested in developing testing interventions to reduce psychological distress and in decision-making, clinical communication, and in and around a number of issues which are really key to head and neck cancer. So I'm going to let Gemma speak and I'm going to go on mute. Thanks, Gemma.
Oh, thank you. Right, let me just share my screen. Hang on a minute. Okay. Can you see that okay? Because I can no longer see you.
That's perfect, Gemma.
Yeah, is that okay? Perfect. Oh, thank you so much for having me along this evening. I should warn you, so I live with my husband, my 7-year-old and 5-year-old, and a cat. And the husband is quite well trained, but the 7, 5-year-old and the cat are less well trained. So I apologise if any of them gate crash tonight. They have all been banished, but they don't always adhere. So hopefully it'll just be me. And I'm going to be talking today about quality of life in older adults with head and neck cancer. And this is sort of an overview of some of the work we've been doing within the survivorship theme at the Head and Neck Cancer Centre and also sort of more broadly. So tonight I'm going to talk about what do we actually mean when we use the term older adult. What's head and neck cancer like for older adults? And specifically, what do we mean when we're talking about quality of life? And I'm going to focus on what we know about quality of life, decision regret, and treatment preferences for older adults with head and neck cancer. And I'm going to sort of finish off by thinking, what are we currently doing and what can we do to improve the quality of life of older adults with head and neck cancer? So I first did a presentation similar to this at the Quality of Life conference in Leeds, the end of 2024. And when I was asked to do the keynote for that, I thought, yeah, this is all right. I can do something around older adults. But actually, trying to define older adult is really quite tricky. So I'm going to start tonight with a definition, so you understand sort of what I mean when I'm talking about older adults. So we know that we've got an increasing global population, and we know that a large proportion of the population are aged over 65. And this is projected to rise to around 16% of all people in 2050. And with older age comes increasing risk of multimorbidity. And so NHS England, unsurprisingly, flag in their Improving Care for Older People document that it's really so essential that older people are supported to remain as healthy and as independent as possible for as long as possible, and they receive the highest quality care when they need it. But surprisingly, there is no standard definition of older adult. So the World Health Organization refer to older adults as those aged 60 or over. Most research studies will classify older adults as people aged 65 and over. And more recently, there's been a shift towards further bracketing within that older adult category. So people aged 65 to 74 are the youngest old, 75 to 84 are the middle old, and over 85 are seen as the oldest old. And within head and neck cancer, 70 plus is generally the most commonly utilised threshold for decision making, based on reported reduction in efficacy of concurrent chemotherapy observed in patients above this threshold. So when we're talking about older adults, hold in mind that some studies are using this to refer to 60 plus. In head and neck, it's generally 70 plus, but the range is quite variable. So the NHS takes a sort of looser approach, and they consider frailty and comorbidity alongside age. So rethinking about biological and chronological age. So they say generally someone over the age of 65 might be considered an older person. It's not easy to apply strictly because people can biologically age at different rates. So for example, someone aged 75 may be healthier than someone aged 60. Instead of simply age, frailty has a bigger impact on their likelihood of requiring care and support. So again, really important to hold in mind when we're thinking about quality of life, decision making for older adults, that there's huge variation in how people self-identify and sort of their biological versus chronological age. And there's similar sort of challenges in trying to define quality of life. It's quite a nebulous construct. So the World Health Organization define quality of life as an individual's perception of their position in life in the context of their culture and value systems in which they live, and in relation to goals, expectations, standards and concerns, including all emotional, social and physical aspects of life. And health quality of life can be further broken down into subcategories, one of which is health-related quality of life. So thinking specifically about quality of life and its relationship with health. And this is usually assessed via questionnaires, and questionnaires can cover various domains, so physical domains, social domains, and so on. But there's lots of different measures of quality of life, and unfortunately, there is not one specific to older adults in a head and neck cancer context. So there's general health-related quality of life tools, and you might be familiar with tools like the EQ5D or the SF36. And then there's cancer-specific tools, so the EORTC is a good example there. Then there's head and neck cancer-specific tools. So again, the EORTC has a head and neck module, but it's not older adult specific, nor is it validated specifically for older adults with head and neck cancer. So again, when we're looking critically at what we know about quality of life in this context, we need to hold in mind, are we actually measuring what is important to older adults? And I suppose that brings me to some of the challenges in optimising quality of life for older adults with head and neck cancer. And one of the sort of key areas of research focus has been around decision making, because we know lots of factors play into decision making, so prevalence, stage, treatment options, side effects. But we also know that there's a lot of additional considerations potentially when working with older adults. Things like frailty, potentially a degree of cognitive impairment, independent living, health literacy and health status, knowledge, preferences, family support. So there's lots to hold in mind when we're thinking about treatment planning in terms of quality of life and patient preferences. But unfortunately, little is known specific to older adults in a head and neck cancer context, which means clinicians, patients, family members, even research findings and guidance are relying on more general knowledge rather than older adult head and neck cancer specific knowledge. And I'm going to break from sort of more academic findings here, just to give you some examples of how this plays out in the real world. So I've got 4 quotations from a qualitative study that myself and Joe Patterson supervised for a doctoral trainee last year, who was looking at carers of older adults with head and neck cancer. So she was interested in what is it like to provide care to adults aged 75 and over. And these are some of the quotations from that really sort of speak to some of the competing issues and considerations for this population. So this was a carer saying, you know, it got to the point where, and it's an awful thing to think, but it got to the point where actually deep down inside, I was thinking, I hope he isn't cancer free. I really hope he isn't cancer free, because if this is what he's got to look forward to for the rest of his life, with his quality of life being so poor, I actually hope he isn't. As it so happens, touch wood, you know, he's massively improved now. He's never going to be that 80-year-old who's climbing Snowdon anymore. And he's obviously had to give up work. You know, his diet isn't brilliant from an eating perspective, but he's pain-free, which is the main thing, as long as he's pain-free. And this was someone who cared for an older adult who was blind. And they said, it's different, isn't it? Because Kay's blind. So the situation is completely different to a person who can see. Because when he was in hospital, all the men that were done, they were up, they were walking around, and that's how they healed quickly, because they were up and walking around. They could see and they could look after themselves, but he couldn't. So it's a different ball game for a person who's got, you know, who's blind. And this quotation was from a carer who was feeling really lost and trapped in the system. And she said, you know, I don't know who I'm supposed to contact. Her symptoms are getting worse. I'm getting fobbed off with the COPD team, but she's having the camera down and they're saying it's not her throat, but her quality of life is so poor. I've made an appointment with the dentist so we can check her mouth out just in case. I thought if we try and exhaust all other avenues what it could be, then I'll ring the palliative care team and say, right, I really need you to get involved now and not later. And finally, this was someone caring for a mum who had a diagnosis of dementia, who said, Mum has dementia on top of all of this, so she's got capacity and stuff like that, but her short-term memory isn't wonderful. And within that as well as processing information for her can be a little bit different. So I kind of like often have to reiterate what's going on for her, like what the doctors have said. So I think those examples really sort of bring alive the issues that this patient cohort face day to day, both in terms of identifying and noticing symptoms, knowing who to contact, which team, when symptoms progress or change, trying to understand what may be symptoms of pre-existing health conditions, what may be new, and trying to juggle demands of cognitive impairment, with pain-free living being seen as a priority rather than survival. And the reason I kind of shared these is because we know this is a problem and it's only going to get more of a problem. Over 12,000 new cases of head and neck cancer are diagnosed annually, and we know the highest incidence is in adults aged over 70. And most people present with locally advanced or metastatic disease, with around half experiencing recurrence. And treatment typically falls into 2 camps. So treatment with curative intent, typically surgery and or chemoradiotherapy, comes with a lot of side effects. And age, frailty, polypharmacy, so being on lots of different medications, increase complications. But treatment with palliative intent, whilst it can, if it's implemented early, can improve quality of life, family burden, survival, it doesn't prolong life. So survival on a palliative pathway is typically less than a year. And the goals are around helping people to to maximise quality of life in their last months or years. So it's very much around pain and symptom management. And we know more broadly, older adults want to be involved in decisions about their care, but they're underrepresented in research and in clinical trials. Often age, comorbidity are exclusion criteria for trials. And what that means is that guidance that's based on the results of clinical trials often neglects issues commonly affecting older adults. So things like frailty, things like balancing activities of daily living, trying to maintain independence, which means that when older adults are trying to make decisions around treatment, often medical narratives kind of dominate here, which is therefore really challenging in terms of decision making, because we know older adults treated with radical surgery are more disabled than pre-treatment, with greater dependency, greater care burden, and greater frailty risk. And we also know that older adults are more likely to be directed towards palliative care or treated with less aggressive strategies than younger adults. So it all creates a sort of perfect storm. We know head and neck cancer is a particularly challenging disease. We know its treatment can lead to lots of physical and psychosocial sequelae, and these can persist long term. And anecdotally, we can see the impact on quality of life. We need to understand how older adults experience head and neck cancer and the impact on quality of life. And this feels particularly important given that evidence is limited to guide decision making, symptom burden is substantial, and uncertainty is really high. So what I'm going to go on to present now is some of the literature that we do have, some of the things that we do know about older adults, starting with factors influencing quality of life for older people with head and neck cancer. So this is a review that's a couple of years old now, and it's one of Sherrod Semple's with Simon Rogers. And the aim of the review was to determine and summarise factors influencing and impacting quality of life for older adults aged over 65 with head and neck cancer. And the review included qualitative studies, the review included 10 quantitative studies, and findings were broken down into the impact of head and neck cancer on quality of life and how quality of life influences treatment decision making. And I'm going to walk you through these findings. So in terms of physical functioning, compared with younger patients, older adults were less physically active, both pre-treatment and post-treatment. And that's sort of expected. We would expect as someone gets older, they are potentially going to be less active as aging leads to loss of function, loss of muscle mass. So the first conclusion from this review was kind of regardless of treatment, effort should be made to promote physical activity for older adults, both pre and post-treatment, to optimise physical functioning. Looking at psychological functioning, compared to younger patients, there was no difference in the depression scores of older adults, but importantly, both groups scored really highly. So there's unmet psychological need there, regardless of age. And interestingly, older adults actually reported more body image distress than younger adults and used different coping strategies. And again, sort of thinking about implications, people need to be screened, people need to be supported, particularly around coping. But this isn't necessarily unique to older adults. There's psychological need here, regardless of age. It's just sort of how that manifests may be slightly different. Thinking about social functioning, older adults reported no difference compared to younger patients. And, it was really nice finding that both groups were satisfied with the social support that they received. But interestingly, the social context of older adults had an influence on treatment. So people who were without social support or were widowed were less likely to receive standard treatment than those that had social support around them, which again sort of points to the importance of thinking about emotional and informational support needs and how they play a role in shared decision making, particularly for older adults who perhaps don't have the same support network or support system around them. So there may be a greater role for allied health professions or supportive care services in decision making for older adults. Thinking next about older adults and eating and drinking problems, again, so older adults had more difficulties both physically and socially with eating and drinking after treatment compared to younger adults, with a greater requirement for peg feeding. And this necessitated much greater reliance on informal family caregivers, which, when you contrast with the previous slide around sort of access to support, really again highlights the unmet need there, and the need to really be sort of thinking about what support an older adult may have to go home, particularly if independence is contingent on informal care and informal support. Thinking about speech, older adults have more speech problems, but again, sort of like mood, speech difficulties were commonplace regardless of age, which again sort of points to the need for pre-treatment baseline assessment and intervention with structured long-term follow-up when needed. And when we think about how quality of life influenced treatment decision-making, interestingly, older adults didn't receive standard treatment, so mostly radiotherapy, as often as younger patients. And this was related to, like I flagged earlier, marital status, but also factors like being diagnosed at a greater, more advanced tumour stage, living with more comorbidities. But importantly, older adults perhaps considering length of life as less important than quality of life. And literature suggests that a third of adults actually changed their mind about pre-treatment decision making. So the ultimate conclusions of the review is that a comprehensive geriatric assessment with an integrated health-related quality of life assessment is needed. And there should be a shift away from chronological age and towards greater consideration of context, including frailty, comorbidity, but importantly, social and informal family carer support, with the need for multimodal rehabilitation emphasised. Okay. So more widely, McDowell conducted a broad narrative review of health-related quality of life. This was just in older adults with squamous cell carcinoma of the head and neck. But they concluded that older patients actually show greater resilience in health-related quality of life and psychosocial outcomes than younger patients. But importantly, with the caveat that older patients included in most of these studies were considered robust enough to treat with radical treatment. We should, in fact, be more aware of the support that younger head and neck cancer patients may need across multiple health-related quality of life and psychosocial distress domains following treatment, despite their perceived physical robustness. So again, it's highlighting the importance of moving beyond age to consider broader context when thinking about psychosocial outcomes. So a couple of years ago, Joe, Simon, myself, and a few others worked with Emma Fay to think about treatment priorities and decision regret in older adults. And whilst our scope was quite broad, we wanted to identify the priorities of older people and factors that influence treatment regret. The literature base was really underdeveloped compared to what we expected. So we were able to include 4 studies spanning the US, Canada, the Netherlands, so nothing in the UK. Only 1 focused on treatment priorities and 3 focused on decision regret. And older adults' priorities, the vast majority were prioritising maintaining independence. Around a third flagged life extension as important. But again, so when thinking about secondary priorities, a third, it was around maintaining independence and living well. And again, these findings were influenced by living circumstances. So those living alone prioritised reducing pain or other symptoms. Those living with family prioritised life in extension and maintaining independence. And interestingly, It's similar findings to studies of patients with a lower median age, suggesting cures are high priority for patients regardless of age, but quality of life is more important for older adults. Importantly, though, this wasn't a qualitative study. It was quantitative, and it's really important to flag that this research isn't a surrogate for eliciting preferences from patients. So patients should be asked, this should be a kind of core part of decision making. When thinking about decision regret, one study looked at decision regret, and there was mild decision regret across the cohort. But again, this was associated with factors like frailty, dependence, and mood. And decision regret often manifested as body image distress, which may account for the correlation that we spoke about earlier, where older adults experience greater body image distress than younger adults. And again, strongly influenced by contextual and social factors, things like degree of social isolation, age, mood. So existing research starts to give us some clues about older adults and their unique experiences, but most studies are quantitative. When we're measuring quality of life, it's self-assessment. It's usually the past week. And like I flagged right at the start, there isn't a sort of gold standard measure of health-related quality of life for older adults with head and neck cancer. So people are using lots of different tools, some better than others, sometimes generic tools, and that makes it really difficult to compare across studies. What we don't really know much about are patients' and carers' experiences, but we also don't know how to accurately capture these. When should you talk to people? How should you talk to people? What should you ask? What's important in terms of impact as a research priority? And we need to really sort of shine a greater spotlight, particularly thinking about intersectional experiences. So we know very little about older adults as a sort of broad group, but within that there's huge diversity in people's experiences. So we don't know about the experiences of older adults with cognitive impairment, for example. We don't know about autistic older adults. We don't know about older adults that live with long-term conditions that impair communication or cognition. So there's a lot more work that we need to do. And when I presented this about 14, 15 months ago, these were the next steps. So the priorities for our research group were to think about actually how are decisions being made? So how do MDTs make decisions about treatment with and on behalf of older adults? How can we better support older adults to make the right treatment decision for them, and not treating them as a homogenous group, but considering those intersectional identities? What are the experiences and unmet needs of the people that are providing care to older adults? And is there scope to improve the experiences of older adults and carers through peer-to-peer support? And this is where we're up to. So we have Joe and I have a doctoral student who is exploring MDT decision making. She's interviewed 11 or 12 clinicians from around the country for a range of professions, shining a spotlight on actually what factors do they consider when making treatment decisions with and on behalf of older adults. So we would hope that will be finished by summer and we should have a better idea of this sort of piece of the puzzle. We've submitted a grant application to the NAHR Research for Patient Benefit Scheme that's under consideration at the moment, to explore decision making in more detail. So sort of ask older adults, ask the people supporting them, ask the clinicians, actually how are decisions being made? How do you feel about those decisions? And collectively, can we come together to co-produce guidance or support to aid decision making in this context? We've completed this study and I'm going to present the findings of that in a couple of minutes, and that is being submitted for publication. And peer-to-peer support study is underway. So this is funded by, again, the Research Patient Benefit Programme. And whilst it doesn't specifically focus on older adults, we're hoping that there will be some insights from older adults that we'll be able to extrapolate to draw some conclusions. So this slide presents the findings of that carer study that I mentioned earlier. And the research question was, what are the experiences and unmet needs of carers of head and neck cancer patients aged over 75? And the title, I think, sums it up perfectly. So we are not forgotten, but we're an afterthought. So Sharon, who's our doctoral trainee, interviewed 13 carers who were aged between 42 and 85, who were caring for adults aged between 75 and 87. And her findings were really interesting. So all carers spoke about the relief of a diagnosis, but with that, the kind of the process of seeking a diagnosis and receiving that diagnosis resulted in quite a lot of lack of trust in the system. So people were perhaps misdiagnosed or sent to different organisations or services before that diagnosis was given. And carers had to manage and navigate a lot of the challenge and uncertainty that came with that. Once diagnosed, carers spoke about how, whilst they themselves know the patient best, their voice wasn't sort of first and foremost, understandably. But as demands of caregiving rose in terms of the practical support and emotional support that they were giving to their loved one, carers felt really unheard and really lost. And that's how they described us. We're not forgotten, but we're an afterthought. And then finally, carers spoke about how it felt to be the only person that their loved one felt safe and supported with, but the impact on them of that sort of that role reversal, the uncertainty that comes with providing care, and really trying to navigate those sort of mixed and often contradictory feelings alongside it. And Sharon mapped this really nicely to a model called the stress process model, which sort of got us thinking about how people's background, how kind of the experience of head and neck cancer diagnosis, but then the sort of the secondary impact of that in terms of loss of role, loss of function, loss of sort of additional role strain, really sort of takes its toll on carers and can really impact on their well-being across lots of different domains. And gave us some clues about potential mediators or important factors to consider in that relationship. So hopefully we'll be able to pick some of that up with future work and really sort of move towards thinking about how we support carers better in this sort of landscape. So that's the end of my presentation today, but I welcome any kind of questions or reflections. Thanks very much for listening to me. I'll stop sharing my screen now.
Thanks very much, Gemma, and you've filled the room. We've got dozens of people online. We've got a question from Terry. Thank you for the talk. It was about decision regret. And I think some of us who've sort of been in the driving seat, I suppose, with patients and having struggled to consent patients and elderly patients, the last thing you want is to be 6 months down the line and they say, look, my quality of life is awful since I've had treatment. I wish I hadn't. And I think that might be particularly a concern that's more common in the older adults. And so perceived quality of consent versus decision regret, that was the sort of question, and how difficult informed consent is.
I think it's a really good point. And I guess sort of thinking about consent as not just a one-off thing, but something that is going to be ongoing throughout treatment potentially. So if somebody's like living with cognitive impairment or their capacity is fluctuating, actually what they consent to in the first instance may be very different when they're presenting for radiotherapy for the first or second time. And one of the things I sat down to do this week was try and update this talk, because it was November 2024 that I gave it, and I was disappointed that actually very little has moved on in this field, this sphere. And we don't know enough about consent in this context, or how to optimize it. And one of the things that we've put in for with the research patient benefit money is trying to unpick that a little bit. But I completely agree, it's a really important area, and one that definitely needs a spotlight shining on it.
Yeah, I mean, my reflection again, I think Terry comments on this, is that my personal dealings with older patients, I've actually got an operation on an 89-year-old this week, is massively influenced by who comes in the room with them and the support network. So the things that you've talked about in your stress process model, they're at risk of isolation and then being emotionally overwhelmed. All of that essentially goes away if they come with caring relatives. And you get the feeling, and they know that they're going to be there in the long term. It's not just for the first appointment. They're going to be there through treatment and after treatment. And you get the feedback. And usually that's very positive. And occasionally we've had this thing where, it's quite hard to get through to the patient, but the patient actually doesn't want treatment, but the relatives feel guilty and they should have everything. And that's a hard one to unpick. And I'm sure we've had all consultations with relatively elderly people, and you ask them a question and they immediately turn to their eldest daughter to answer the question. And that's a tough one. But I think, yeah, that stress process model looked really valuable because, and I think, right at the bottom there were the relatives, and the social support was really important. And you can even titrate how worried they are by how many relatives they bring with them. Like for a bad appointment, there's 5 in the room. As things get a little bit better, the numbers go down maybe to one of their grown-up children and what have you. So I think that's worth. I was going to ask a question which intersects between your talk and the first talk of this series about immunotherapy, because everything in head and neck cancer is about immunotherapy this year. That's what it's all about. It's the hot topic, and I wondered if anybody has done any research on how using immunotherapy, because it's much more likely to be tolerated in elderly patients than chemotherapy, has been studied, attitudes towards it. And then there's the biological side of it, is whether their immune systems are capable of responding to immunotherapy, and therefore what the clinical benefit will be, and what attitudes to it. And because I think in chemotherapy, which has been one of our additional treatments, it's been reasonably clear that elderly people can't benefit from chemotherapy. Where's the cutoff? Should there be a cutoff is the argument. But I wondered if anybody's looked about more the nuts and bolts of immunotherapy in older patients, because it's going to be a hot topic.
Yeah, so it's been done sort of in cancer in general. There was a narrative review published, I want to say last year, but it's 2024. As far as I'm aware, sort of detailed study in head and neck hasn't yet been done. I'm loving doing this talk because it's given me so many ideas of sort of areas to move forward with. It feels really important.
Simon's got a question.
Hi, Richard. Hi, Gemma. Thank you so much for what's a wonderful talk. I've got just a couple of little points. I was taken by the BMJ article a couple of years ago now, 2024, and this is so pertinent to what we do, where they were reporting that in England or Wales there's 15,000 people over the age of 100 at the moment, 15,000, and that projected figure for 2025, which seems a long way off, I'll be dead by then, is 500,000. And that's 500,000 over 100, let alone over 90. So the older group of patients is really going to become so important in our clinical practice. And then I was taken by the fact that when you look at the issue in the elderly between cure and survival, patients want cure, in my reading of the literature, because they're fearful of death from the disease and the uncertainty of the disease. They realise that they may well have limited survival, but they want treatment because they want cure, because of the uncertainty and fear of the disease. And then that leads me on to, well, how much do we know about how good palliation is and the implications to the family and the carers in trying to take the elderly patient through cancer treatment or palliative treatment, and those two distinctions between palliative, where we know that death was within a year, versus curative and the treatment burden. And then it made me sort of think about, and I don't know what views you've got about this, is that with the end of life bill 2024, assisted dying, my brother's wife's dad had early dementia, and he comes from Holland. They live in Holland, and he's not even 80. And a few weeks ago, he had assisted dying in Holland, where he went through that process at under 80 because he had early dementia and his life has ended. And how much will we bring in the terminal illness of adults and so on into head and neck, where we know that potentially their prognosis is less than 1 year, and should we actually be refocusing our issues in terms of supportive care rather than curative treatment?
Yeah, and I guess sort of as you were talking, Simon, I was thinking around decision making and informed consent, and actually sort of what's driving decision making in this context, and is it a truly informed decision, or is it being driven by fear, by anxiety, by sort of distress, rather than objective appraisal of sort of what reality may be like? And I know in other cancers, so we've done some work in a team I used to work with did some work in risk reducing mastectomy, and sort of why people opt for that versus sort of living and monitoring, and it was all fear driven. So it was opting for risk reducing surgery to reduce the fear of cancer recurrence or progression rather than reduce the risk. So it makes me think about what's driving these decisions, and is there a role for psychologists or for people in helping support people to make informed decisions that aren't based on heuristics of fear and yeah.
And I actually agree with that. I mean, the problem you'll have is a patient who really doesn't want to have treatment, as Richard alluded to, but actually goes through treatment because their family want it, because they don't want to use the loved one, and all of those difficulties. And I think in these rather complicated scenarios, actually having a clinical psychologist help unpick the priorities and the concerns and the fears of a patient is really helpful to the multidisciplinary team, and would really augment the multidisciplinary team process in terms of treatment decision making.
Yeah, I'd agree. And I think sort of in terms of carer support as well, you know, I imagine supporting someone with living with decision regret and knowing that you've inadvertently shaped that decision making because the person perhaps has gone through treatment because they feel that they owe it to you or you want them to. That's a really difficult burden to carry in and of itself. So I think sort of greater support and decision making could benefit not just the patient, but also the support system around them as well.
Yeah, I agree, because in the younger patients, of course, it's a bit more of a given. Let's go for survival. But as you know, that's why you're having this topic. It's such a difficult topic, and hopefully there'll be more data coming forwards to be able to give better information and guidance to and support to the elderly group of patients as we come to treat them. So I've really enjoyed the presentation. Thank you very much.
Yeah.
Thanks very much, Gemma. And I think, you know, I don't know whether the great public out there realise that essentially, if you look at the big picture, cancer is disease of old people. And of course, when you see a young person with cancer, it's very visceral experience for the patient, the family, and the carers, and it really strikes with you. But if you look at the numbers increase with age, because the accumulation of genetic mistakes in your cell and the ability of the genome to repair itself, eventually you reach a tipping point. And I guess if you're one of those that reached 100 and you've not had any experience of cancer, you're probably in the minority. By the time you get that old, it's just like an accident of living longer than we're designed to live, really. A lot of cancers that we treat. And, you know, I think that maybe that's something that we need to educate the public that, you know, for many of these diseases, cancer can be a chronic disease, and it is almost to be half expected as you get through, if you live in your 70s and 80s. And even in my career, the beginning of the career, if you didn't look after your health very well and you come from a northern working class town, you didn't make it much past 65 years old. Whereas now people routinely live past 75 with frailty, with comorbidities. And you know, it's a challenge for us. So I think it is a really pertinent area for research. And I say, just making me think about how what you've presented today could interact with other things that are happening in the Head and Neck Centre, and our research interests in, you know, in the laboratory or in clinical trials could be really interesting. And I think we should talk about immunotherapy in elderly people, whether it's going to be a thing and how it's going to find a home.
I agree, because there's data on efficacy, there's not data on acceptability, experiences, viewpoints, role in decision making. So yeah, hopefully this will be the start of a few of these talks where we can continue this trajectory, because it's certainly something that we're really passionate about and that we're going to carry on working on.
Thanks for everybody for coming, and thanks to Gemma for such a well-balanced talk. And we hope we've been able to put a really multidisciplinary and varied set of lectures together. We appreciate not all of them for everybody, but I think it does us all good to listen to all the different things. And I think it really does reflect the strength of all the collaborations we've got in the Head and Neck Centre, because we haven't really reached outside the Head and Neck Centre yet. So just as a reminder, there isn't a talk next Tuesday evening. We've got a gap. And then the last talk in this series is jointly from Mered and Terry, and it's 2 weeks today, which is whatever the 2 weeks today is. I'm going to guess the wrong date in February. The 10th. There we go. Somebody's got the diary in front of me. So I'm going to draw things to a close. Thanks to everybody for coming. We've had a super audience of I think nearly 40 people tonight. So thank you, Gemma, and see you soon.
Thank you.
Bye bye.
Thanks everybody. Take care. Bye.
Thanks, Gemma. Cheers.
Bye.